Hello, everyone. Welcome to Concordia University's Fourth Space. Thank you for joining us for today's event, Beyond Blame. Obesity is a disease, not a choice. Now, to help situate you, we are streaming to YouTube, live from Fourth Space. We are located here on unceded Indigenous lands in Tiohtià:ke, Montreal. Here at Fourth Space, we work with our university community to help mobilize knowledge, co-creating daily activities that examine research questions, projects, things in development across the university. Now, today we are running the event as a live stream Zoom meeting, so those of you joining us there, if you have any comments or questions, please pop those into the chat, and we'll do our best to read those out during the Q&A. And for those of you joining us here in the space, if you have any comments, questions, just raise your hand. We'll bring a microphone over to you. Okay. With that, it's very much my pleasure to hand things over Concordia Public Scholar this year, also a PhD candidate, the Department of Health, Kinesiology and Applied Physiology here at Concordia, Muhammad Ilyas Nadeem. Muhammad Ilyas, welcome in.
Thank you, Douglas. Hi, everyone. Good morning. My name is Muhammad Ilyas, and I'm a third-year PhD candidate in HKAP department at Concordia University. So I'm honored to welcome you all for today's panel discussion, Call to Action, Beyond Blame. Obesity is a disease, not a choice. So we are here to challenge deeply rooted stigma and shift the conversation from shame to the science and explore how research, policy, and lived experiences can intersect to create more compassionate care. So we are joined by the phenomenal experts in the field of obesity with the different expertise, virtually and in person at Fourth Space, and I welcome you all for the conversation. So today's goal is not just to talk, but it's to listen and feel and hopefully leave with the commitment for the evidence-based and empathy-driven care, obesity care. So let's begin with the grounding ourselves into the science with the keynote speaker from Dr. Sanjeev Sokalingam. So before we begin the keynote speakers, so I would like to introduce my panelists here shortly. So virtually we have Dr. Sanjeev Sokalingam. So he's a Senior Vice President of Education and Chief Medical Officer at the Center of Addiction and Mental Health. He is also Professor of Psychiatry at the University of Toronto and the Scientific Director of Obesity Canada. So he specializes in integrated mental health and obesity care with a focus on innovation and education. Then we have Ms. Jennifer Braun. She's a registered dietitian and a certified bariatric educator. And she works to reduce weight stigma and improve obesity care in bariatric special clinic at Ottawa Hospital. Then we have Dr. Jose Murray. So he's a professor of medicine at the McGill University and a director of geriatric medicine at MUHC. So he's a senior scientist and expert in aging, nutrition, and obesity-related chronic conditions. In persons, I have the first guest on my right. She's my professor and supervisor, Dr. Silvia Santosa at the Department of Health, Kinesiology and Applied Physiology. And she's also Canada Researcher in Clinical Nutrition, and her research focuses on obesity, fat tissue, and metabolic diseases. Then next, she's also one of my teacher and course instructor, Associate Professor Dr. Angela Alberga from the Concordia University, and she focuses on weight stigma, body image, and health equity in pediatric obesity. And she works to advocate for reducing the weight-based discrimination in healthcare and society. And my next guest, Professor Dr. Julie St-Pierre. She's an associate professor at McGill University, and she is the professor of pediatric obesity as well. And Dr. Angela Alberga and Dr. Julie St-Pierre both are the lead co-authors of clinical guidelines for pediatric obesity this year, which were released a couple of days ago on April 14. Thank you and welcome all. And over to you, Dr. Sanjeev.
Thank you so much, and thank you to the yourself and the entire group for the invitation to kick this off. And I'm very privileged to be part of this esteemed panel. I'm looking forward to our discussion. So I have the honor of starting with a brief presentation. Mohammed, you entitled it as The Science of Obesity, but I'm going to say it's not so much a scientific talk, but more a call to action for us in terms of how we approach obesity care in 2025. So I will just move to share my screen. Just give me 1 second here as I here. Thank you. Can you see the full screen thumbs up? Thank you so much, Jennifer. Wonderful. So the title of the talk that was given to me is Understanding Obesity Beyond Personal Responsibility. And I'll just say a few things for about me. And so I'm here partly, I do research in this area, particularly related to interface of mental health and obesity, but I also have training as an obesity medicine specialist. So I'm a psychiatrist and obesity medicine specialist. And I guess one of the things that I hope will come through as we talk about obesity care in Canada in 2025 is that we are looking beyond kind of weight and BMI. We're looking at health. We're looking at mental health. And the brain is important, no surprise, to a lot of the things that we talk about in obesity, in addition to the whole system that includes environments, families, and healthcare providers as well as part of that circle. So I'm going to go through and again, just try to set the stage at a high level, but I know with this superstar panel, we'll have a very fruitful and more in-depth discussion. And again, this will be a review, but for all who are viewing, just to really situate where we are with obesity care in Canada, that nearly 1 in 3 Canadians live with obesity. You can look at estimates across the country, whether that's 9 to 10 million Canadians, and that obesity is a chronic progressive disease. And you'll hear me repeat that as the mantra for the entire presentation here, right? Obesity is not a choice. It's not about willpower. It is a chronic disease. And the fact that obesity is also associated with more than 200 chronic illnesses is really important, and especially as we think about how how new treatments are evolving in obesity care. So you have a list here of cardiovascular and metabolic diseases like diabetes, respiratory diseases, osteoarthritis, cancer. You can throw up depression, anxiety in there as well. It speaks to a few things that as we think about obesity care in Canada now, we have to think about, one, how do we ensure that obesity is no longer viewed solely as a risk factor? People who've heard me present before, I'll just quote something. I live in Ontario, and the Ontario Hospital Association projected the impact of chronic disease in 2040 on our patient population and the health crisis that is soon to emerge. And many of the chronic diseases listed are these ones here listed on as an associated illness to obesity. But obesity was not listed as a chronic disease, first and foremost, in that report. It was listed as a risk factor. When you start to do that in public health documents, healthcare reports, it further adds to the stigma and disparities that we see in obesity care and kind of perpetuates this, that obesity is a side thought or a risk factor or not a sole focus, and it really does not do justice for the patients that we serve. So just my point there that I want to reiterate and hope we'll build on in our discussion. I also just feel like we need to level set about the myths related to obesity. We have a lot of experts on the panel here who do this research all the time about the impact of stigma and discrimination that are experienced by people living with obesity, and that our goal is to provide compassionate evidence-based care. And so there are 5 facts or debunking the myths, and one is, I've talked about it, obesity is a complex chronic disease. I think it's important because we also have to undo the narratives of quick fixes and magic bullets that have been perpetuated by society, that if you go on this diet or take this supplement, you will end up treating a chronic complex disease. And one of the things I'm reminded in my kind of clinic every week is that every patient that I see who's seeking care for obesity has a unique story, a unique set of contributing factors. And it's important for us to understand this, both from a care perspective to help guide us into kind of collaborative treatment approaches, but also it's important for us to further advance our research to understand how we can further target treat and in some cases prevent some of this as well. I mentioned that obesity is associated with more than 200 weight-related health conditions, and it really underscores that notion that treating obesity can also be considered as working upstream in health, right? If we treat obesity early and effectively, we may be able to prevent other health complications that can be significant burdens in addition to living with obesity for many individuals in Canada. Obesity is driven by biology, not choice, the second kind of fact. And I'll just speak to the fact that we have to move away from this eat less, move more notion as the sole treatment or mantra for obesity, and to understand obesity has genetic, environmental, behavioral, and social factors, including large inequities from social determinants of health as well that contribute to increased risk of obesity. And then the other factor is that we, as a biological disease, we need to move beyond simplistic approaches to define and measure obesity, such as weight and body mass index. We know where body mass index came from. It came from population-based approaches, primarily based in insurance data, primarily based in Caucasian men, which doesn't generalize to many of the patients that we see. We still use it as a screening measure, but we need to be much more sophisticated in our approach in defining obesity, which I'll talk about shortly. The other part of this is that the biology, and this alludes to the fact of the science, that we have a better understanding of how our brain is impacted or influences obesity and our behaviors as it relates to obesity. And what I'm alluding to is the fact that we have a greater understanding of homeostatic regulation that happens in the brain, in the hypothalamus, our reward pathways in something called the mesolimbic system in our brain, and how other parts of our brain, like executive functioning, play a role, and how all of our treatments that we provide across our pillars of treatment, from psychological, pharmacological, and surgical, have this way to influence this neurobiology directly or indirectly through hormones and other kind of gut-brain interactions. Again, I did allude to this third point. Obesity can impact health early, and we just released our pediatric guidelines for obesity through Obesity Canada in collaborations with many of the leading investigators here who are present and not present here. And I think it really is this lifespan approach, and that recognizing obesity can start early, the negative impacts, both psychologically, stigma, and physically, and our approach is to identify and intervene early using a multimodal approach. Obesity is treatable, and we're seeing this more and more as the science and evidence emerges. And those three pillars of behavioral or psychological, surgical, and pharmacological are key. Just to reiterate that obesity care and weight loss are not the same, right? We are thinking more holistically about obesity, and how we define obesity is as a chronic, complex medical condition that is as a result of excess fat tissue that impacts one's health negatively, and health outcomes leading to impairment, right? And so there are ways to measure that, the impact on other health outcomes, quality of life, mental health factors. All of these are so critical for us, and we have treatments available. And that lastly, and probably most importantly, weight bias, stigma, and discrimination harm everyone. And that we know that unfortunately, many of the people I serve in my clinic who are living with obesity have had tremendous and harmful experiences in healthcare related to stigma and discrimination. And on top of that, many in society as a whole. And we really need to do better in terms of recognition of this and using strategies to mitigate and address weight bias and stigma in society. So I'm going to just go through the last few slides here just to say that we need to treat obesity like any other chronic disease. We still have that bias that's pervasive. We have to, as a society, and as a healthcare provider, we all need to unlearn what we've been taught or been fed, and in terms of some of the messaging. People see obesity as something personal, as a personal failing instead of a chronic disease. We have effective treatments, but most people can't access them. And that is in part due to cost, a lack of understanding, but also stigma related to that. We can come back to that in our discussion. And that despite the evidence and research evolving, changes in healthcare and health systems take a long time. You may know that when something comes out as a research finding that has robust evidence, it can take 15 to 17 years before that can be translated generally into clinical practice. And we need to think about how do we shorten the gap for chronic diseases, particularly like obesity, given its profound impact. And then the last few slides here just will highlight that if we don't take action from a system perspective, for me as a healthcare provider and many others, collectively as a research collective to advance the science and our understanding, we have significant impacts economically for Canada, which is really important for us and been helpful to communicate to government as well, that the cost of not treating obesity is $27 billion. Again, about $6 billion related to healthcare costs, so people going to hospital, getting treatment, but over $20 billion due to indirect costs, which is, and this figure as a whole is 20% higher than previous estimates. And I'll just say that what is that indirect cost? That has to do with work productivity costs. They're 3 times higher than the direct costs, and that's people showing up to work, not being able to do what they normally would be able to do at work due to ongoing chronic illnesses, stress, and other factors. That's presenteeism, reduced workplace participation, reductions in personal income, and that's related to health-related, but also stigma and bias. And we know in particular women face these disparities at a higher rate than men who are living with obesity. Both they make less annually and they're less likely to be employed than men living with obesity, although both groups have significant stigma. And of course, the disability and obesity attributed early mortality also play a significant role in these costs as well. So what we need to do is to think about how do we build this system for better access to treatments and interprofessional or team-based care. How do we help with unlearning where all the things that are no longer valid based on our research and science, so that provider training and support, and that's maybe societal and public health training support, and how do we work with employers to provide better work conditions and workplace interventions to support people living with obesity. And that is linked to care, but also those environments as well. And so I'll just say that this call to action, I thank you for allowing me to speak, and I'm speaking here on behalf of Obesity Canada, that we're committed to working with this group and many others to help advance and translate the research and innovation. We have practice guidelines, a lot of advocacy and engagement, including getting provinces to recognize obesity as a chronic disease, come up with reassessment of their healthcare coverage, and try to develop creative systems and models of care that are more aligned with their guidelines. And then the huge effort for public, patient, and healthcare provider in terms of education and awareness. And so really, we are trying to help co-create with people with lived experience who are part of all of our work. So people living with obesity, including our guidelines, our adult and recent pediatric guidelines, to advance the science and to challenge stigma around obesity. And we hope that all Canadians who feel passionately about this and want to join this movement join us on the journey across all 3 pillars. And I'll just say, these are the guidelines available that I hope will inform and help advance some of the care discussions at a provider level, some patient advocacy tools, and also with policymakers. And then I'll also just share with you that if people want to join us in this learning journey, that there's an array of education modules as well. And I will just say we hope that these discussions will continue, and there are many events coming up in 2026, including our summit as well. And just a plug for that before I hand it over to our panel. But thank you for allowing me to kick this off, and I look forward to the lively discussion to follow.
Thank you. Thank you, Dr. Sanjeev, for such an impressive presentation, highlighting the different aspects of obesity care in Canada and globally as well. So just to recap, so for presentation, you highlighted different aspects, like for example, the 5 facts we should know about obesity, everyone, that is a chronic disease, and there are certain determinants which actually drive the obesity pathogenesis, like its brain is involved, the biology is there, but it's not just as lifestyle changes or the personal choices, and then you mentioned that how it is impacting because it is associated with more than like 200 other chronic conditions, and it is impacting the overall healthcare system. And it is a treatable because the treatments are available, and the only thing is we need to find the equitable healthcare access for all these individuals who are living with obesity so they get treated. And of course, we need to do the advocacy for the weight bias and stigma and the discrimination harm everyone has. So just to build on that, let's begin with our discussion now with the panelists to understand more about the obesity. So my first question is from Dr. Angela Albarga, that how obesity differ from just weight gain?
Just making sure this is working. So the question is, how does obesity differ from weight gain? I think it's really important to understand that, first of all, Sanjeev talked about this really nicely, that there's so many risk factors, there's so much biology involved, mental health, brain health, that's so much outside of individual control. I think probably the most important piece to understand about differentiating weight gain and obesity, or just understanding both together, is just understanding how much is involved that's outside of individual control. That's completely driven by our biology, our genetics, our complex physiology that drives so much about weight management and so many other health-related conditions. But obesity is not about just weight. That's the thing. I think that's the most important factor to decipher, is that when we think about obesity, we think about all aspects that can affect health. And weight gain is really just looking at weight. And the clinical practice guidelines have done a really great job at really understanding how it's not about weight. It's not about energy in, energy out. It's about factors and values and preferences that matter to patients, using a patient-oriented care, and really thinking about reducing stigma and understanding how obesity is so much more complex. And I think actually something that's most important to understand is that we need to address stigma to understand those differences too. Because one of the most important things that drives stigma is thinking that obesity is about just changing behaviors. And it's that they're under individual control, but really it's so much more complex than that.
It's not. Thank you so much. And thank you for framing it in a way that obesity is a disease which has the heterogeneity where a lot of different factors are involved. And thank you for mentioning about the excess weight. And I like that Dr. Sanjeev has actually highlighted one of the point that the BMI is not an only indicator, right? So Dr. Sanjeev, I would like to hear more about this, that how the BMI is not only indicator to classify somebody that this person is living with obesity. I know there are different factors like Dr. Angela just mentioned. There is a biology, there are different values, there are social determinants, right? So could you please highlight more about this? Thank you.
Yeah, I mean, one of the things, again, the American Medical Association just came out a couple years ago talking about the huge inequity and history of BMI, including its racist roots, actually, where body mass index came from. So a very eye-opening kind of statement from the American Medical Association and many medical associations globally. And I think it's just to highlight that we've accepted body mass index as the be-all and end-all of obesity measurement. In fact, if you look at clinical trials, although they are evolving, the ones we've had largely to date have used body mass index as the inclusion or exclusion criteria for who gets treatment. And only until recently have we, for bariatric surgery or medications or generally in treatment, thought about differences in body mass index based on ethnicity, other socio-demographic factors. And it really speaks to the limitations. So I think all of us acknowledge the limitations and the history of body mass index, but we aren't going to do away with body mass index. Unfortunately, we've been inundated with it, and it is built into everything. If I looked at my electronic health record today, the first thing in an assessment is the height and weight to make a body mass index calculation that just pops up on my screen. But I would argue that we use that as a screening measure or a first measure and not the sole measure for defining obesity. It's a measure, it's a piece of information. And there are many other things that we can talk about, like height waist ratios or hip waist height ratios, or other complex measures. And I would argue that if we use the Obesity Canada guideline definitions, and which are more widely adopted about obesity being a chronic disease with excess fat tissue that impacts our health and organs, something like the Edmonton Obesity Staging System, which has been around for over a decade, is useful because it talks about body mass index or some measure of excess fat that we use as a proxy, but it looks at health more holistically, like what are the physical health issues that someone is dealing with? What are the mental health issues? And what are the functional impairments that someone is having socially, physically, and occupationally? And I think this is the way we need to go in terms of redefining what are some of those outcomes and tailoring it to the individual in front of us.
Thank you so much. I like the fact that you mentioned about the different anthropometric measurements that they are being used as they should be used as a screening tool, not to just diagnose or classifying somebody that this person has obesity, you know. So it's from my understanding, it's a kind of estimation of excess fat, but it does not actually tells you or indicate that there is something biological happening inside the body. So there are a lot of different factors like the fat tissue toxicity, let's say fat tissue dysfunction. So just to extend that, I would like to ask Dr. Santosa, because she is working on fat tissue and metabolic diseases. Would you like to please tell us more about that how fat actually affects the metabolic health and how it differs from person to person?
Well, thanks for your question. It's a bit loaded because that's it's a lot of what we're trying to figure out. From our point of view, what we kind of view is that there's a lot of underlying biological aspects with regards to how fat is contributing to our overall health, and what variables actually affect that. For example, do we need to consider whether someone is male or female in our treatment approaches? Do we need to consider, we've looked at individuals with childhood onset versus adult onset obesity. So if you developed obesity during childhood, how does that differ biologically to an individual who developed obesity as an adult? So these are the types of questions that we're trying to answer in our lab. And we have found some interesting things. For example, when we looked at males who exercised, after exercise, we wanted to see how much fat they used. During that exercise, the fat that's located in the muscle, we found that those with adult onset obesity were able to more effectively use that fat in the muscle compared to those with childhood onset obesity. So we do see some differences that are biologically based that might hopefully eventually drive some of the recommendations that we have, or that we start to develop a little bit more so that we can make it more personalized and more customized. So like, for example, maybe we should be looking at an exercise intervention for those with adult onset versus maybe a more different type of intervention or pharmacological or behavioral or whichever intervention for those who developed obesity during childhood. So we are looking at these biological type differences, and yeah.
Thank you. Thank you so much for highlighting the fact that over the lifespan time, like for example, starting from childhood to adulthood, and then over the age for adult individuals who are aging actually. So there are some changes happening, in the body tissues, muscles and fat tissues. So just to shift the conversation to the muscles thing, so I would like to ask a question to Dr. Jose Murray. that could you please extend the conversation about that how bodily changes which are starting from childhood to adulthood and eventually the aging, how it actually affects the fat tissue and contributes to metabolic health?
Yeah. Hi, this is Jose Moret. I'm a geriatrician by trade, but all my research career has been dedicated to nutrition. And for the first 15 years of my career, I was in a nutrition center in which obesity was a topic of great interest. And now that you ask Ilyas about aging effects, for sure, there is body composition changes as one ages. And after reaching the maximum of muscle volume and mass about in the mid-20s, then it stabilizes for another 15, 20 years. But from 45 years of age onward in general, there is decreases in muscle. Muscle being a very active tissue, and the losses start at before you reach 50, and it has an impact in your energy expenditure, and as a consequence, even if you make efforts to maintain the same amount of caloric intake, you will end up spending less. And as a consequence, you become in a positive balance. And this is not because you change your behavior. It's simply what is going on at the biological level. At the same time, and in general, what we observed is that in the mid-40s, etc., your weight start to increase. And the gain you make in general is in fat, indeed. But there's also a lot of changes happening about our lifestyle. From the 30s onward, we become less physically active. We have more means, economical means, as we start working, have revenue to have more transportations with our own car, comfortable cars, so less energy expenditure. Because of the demands of the work market, we also have less time to do activity. And we tend to eat more fast available foods that are usually very energy dense, though they are not nutritional dense. All of this impacts, and as we progress in age and become more and more sedentary, then obviously we are in a very positive balance. And all of this has nothing to do with our evolution, our willingness. We just have to be much more careful because the environment has changed tremendously. I was reflecting in the beginning of this panel discussion, we put a lot of emphasis on the biology, and it's right. I mean, energy is essential for life. And as human beings, we are wired to conserve energy because it's so precious. And this happened with our ancestors that were hunters and gatherers. And they would search for food and energy for hours and days until they would catch a prey and then have energy. And because there was no supermarket around, whenever there was food available, they needed to conserve that energy for the days where there would be no food available. So we are wired to conserve. And look now in our environment. I just wrote down a few observations in which we have an extremely controlled environment in which we don't need to do a lot of distance unless we are willing to do so, because we have access to cars and public transportation, so much available. There's an abundance of food around us. We don't need to walk for a long distance to have a grocery store and access food. We have means to buy food. We are bombarded with ads encouraging you to have access to very tasty foods full of energy, too much fat, obviously, which is very energy dense but poorly nutritional dense. I would say that the rhythm of our lives, there is a strong anxiogenic component to it. And, food can have a calming effect. Usually we eat, we relax a bit, and this makes one adopt a certain style of life without being conscious of it, aware of it. And, my experience is that we human beings, you are beings of habits, a little bit like my dog who's waiting for me when I arrive home to go for a walk. And so we adopt a certain way of doing things, and we don't reflect on it very much. There's so many, biology conditioning our behaviors that eventually there's an excess of weight, and then the risk of having associated consequences appears, have been mentioned before. So I think together with the aging, these also are life habits that is beyond our control. So there's a need to be aware. We have to really now take decisions that before was so natural. You would spend energy just because you're looking for food. Nowadays, it's the reverse. We don't spend energy and we have a lot of food. So
Thank you.
this is some food for thought, isn't it?
Yes, Prof. I mean, I was about to say this, that thanks for highlighting this component of nutritional involvement and fat tissue dysfunction and how it actually changes over the time and throughout your age. So just to build on that, I remember one of the contexts where it is usually said that you need to eat less and move more. And you did mention about changes of lifestyles because of industrialization and modernization. We have adapted certain ways of living, and because of that, of course, our environment is influencing our bodily conditioning, over the age. And thanks for highlighting it. I just want to ask Ms. Jennifer to highlight on this further, that how nutrition actually plays a role in the severity of obesity or fat tissue dysfunction, and how do you see? Because you see a lot of different individuals with obesity from different ages in your clinical setting. So would you please?
Yeah, thank you so much, Muhammad, and thanks everybody for the invitation today. I think there's been a lot of really good discussion around, the role of nutrition, but as Sanjeev had mentioned in his kind of opening remarks, there's a big shift in us having to unlearn and relearn, especially around nutrition. The old, thoughts around nutrition, and we've kind of alluded to this, is, again, that energy in, energy out, or eat less and move more mantra, but that has done a lot more harm than it has good. And, it does come down to the biology. It does come down to how each individual person regulates energy and regulates, their appetite. Whether we're looking at parts of the brain or we're looking at tissues in the body or that interaction, the reality is, for most of us, and Dr. Merez, you mentioned this, our environment itself has changed and our biology hasn't. And we, just like you said, we're wired to conserve energy. I'm mindful of the fact that there's so many pieces of this puzzle that interact with appetite and weight. And when it comes to nutrition, I mean, we have a number of Canadians that are living in, food deserts. So food deserts related to, yes, they might have access to a convenience store or a grocery store, but the food that's there is not, it's not nutrient dense, meaning that it's not going to give our body the nutrients it needs. Or people have, access to more convenient type of foods, less time, there's more stress in people's lives. Financially right now, we've never seen, I think, in modern day history, we haven't seen the consequences of what we're seeing now in the Canadian population around, again, that food insecurity, the lack of access to just fundamental rights when it comes to food and healthy food. And I use the word healthy because I don't want to say all food gets put into a healthy or unhealthy category. It's more around the fact that getting nutrition that fuels those muscles, that allows fat tissue to actually thrive and do what it's supposed to do, which is around metabolism and helping our bodies work correctly. So there's a big piece environmentally, there's a big piece, I think, socially, the social determinants of health is a big piece. But to bring it into how does this relate to obesity treatment, and I want to really, I guess, hit home this concept of unlearning the fact that nutrition and movement and physical activity, but nutrition and activity are important for every single person, regardless of what our weight is or our body size or our health condition. Nutrition and activity is important for every single person. And so when we're talking about nutrition from an obesity lens, we need to recognize that everybody should be eating as well as they can and having access to good food. But when we're looking at treatments, we really need to get to that biology piece and understanding that there's areas of our brain and areas of our body we can't get to. And that's where those treatments like psychological treatments, pharmacological and surgical interventions, so the 3 pillars of obesity care, really help to support the nutrition and the activity piece. And that is a big role in helping to support that shift in reducing weight bias and stigma. The really interesting piece, and I know a lot of the work that Sylvia has done in the past too has looked at the nutrition components of, well, is there certain ways that, or certain foods that can help reduce inflammation or can help reduce some of those negative impacts that our, organ or adipose tissue can process. So I think that's where we're going to see a lot more individualized nutrition care, or what we call medical nutrition therapy. But it really is not a siloed approach. We have to be working all together. This is a top-down and a bottom-up approach. So it's definitely a role that nutrition plays, but is not the most important role.
Thank you, Ms. Jennifer, for highlighting the nutritional component and also mentioning that it's not only nutrition. There are a lot of different factors: lifestyle, your physical activity, and of course there is a fat tissue toxicity, dysfunction, which can be modified, or we can make changes by different nutritional intervention. And thanks for mentioning Dr. Santosa's work. So she's doing the work on how nutritional intervention actually changes the characteristics of different adipose tissues. And it is an important factor, but it's not the only one. And I like it because just to summarize the discussion for so long, for whatever happened so far, the thing is that I noticed that there are a lot of different heterogenetical components, right? We have environment being mentioned here, we mentioned the age, childhood, and then we have mentioned the psychosocial factors as well. How about those individuals who are living with these conditions? When all those kind of comments in the society, I would like to shift the conversation from biology to further to the societal norms, that how it is actually impacting the individuals living with obesity. So just to begin with, Dr. Julie, I would like to ask you the question that from your perspective, what roles does the family and community play in childhood obesity intervention, and how it actually extends towards adulthood obesity?
Thank you. So fabulous discussion so far. It's very interesting to be all together this morning. In fact, the role that families and children and the entire society can play at this point, changing the discussion in obesity. I think it's a bit, it's a tough question, because so far what I've seen in 20 plus years of cares, managing thousands of families living with obesity, childhood, adolescents, parents also living with the disease. it's quite tough for them to advocate right now and to change, one of the most important problem that we have right now across Canada is to modify the shame that the society has internalized, and it's very, on a day-to-day basis, the pain that people are experiencing, is really something that is challenging for them to advocate and speak out loud. So I think that right now our challenge will be to reduce that fat phobia that exists at the policymaker level, the government level. And as long as we cannot break this down by education, by translating the good science that we have in our pockets, it's going to be very difficult for the families to be out there and advocate more. They are trying, but right now, they shouldn't. They don't know who they're talking to. So let's pretend that 50% of the population, as per data, is fat phobia. So you never know who's in front of you and how you can address that. This is true with the healthcare professionals, but it's also true with your neighbor, with the teacher at school, with the daycare people. So it's very tough. And I think that, this is really the main challenge that we need to address, is that to break down that perception that these people are living, with a disease that they are, guilty. They should never come to a doctor feeling ashamed to talk about the health issues that they're having living with the disease. And right now, this is happening every day.
And it's very unfortunate actually, because bringing back to this thing that the things begin with the family, of course. I just want to highlight here that one component is the genetics, there are the familial diseases which runs in the families. I don't know how correct this notion is, but that's how it is perceived, And the second thing, I think it's a coffee maker. So the next thing I would like to ask about that, like you mentioned about the schools, and there are some children who faces this kind of bullying, at the school, and they feel less confident, And would you like to please highlight this one?
Yeah, sure. I think it was in 2019, we did publish at the Canadian Pediatrics Society data regarding bullying occurring in school among 10 years old and less than 11 and older. And we found out that, almost every child below the age of 10 suffered from a comment or something that really affected his self-esteem. And people don't know, but we are very privileged as clinicians to also get the trust of these children, complaining about how it modified their self-esteem. And in 50% cases, parents are not aware of that. So it's always, very sad to learn about this. And most of the teachers don't know how to address that. For sure, there's a lot of efforts that are made to accept, the body image in schools. I think it's getting better, but there's still a lot of work to do. And it starts so early. I mean, even in daycare, I have parents, reporting that they felt, the blame through the eyes of other parents looking at their child, And, sometimes we said it many times today, it's a complex disease. If your child suffers from autism and has rigidity towards foods and develop early childhood obesity, I mean, it's not your fault. You're a good parent. It's just that, you're struggling with something that is, above what we know as a parent who has a healthy kid. So I think it's more dramatic than most Canadian would think of.
Thank you. I think Dr. Angela.
I just want to add to what the Dr. St-Pierre was talking about bullying, and you're absolutely right. I mean, we know from lots of literature to date that bullying for weight-based teasing and making comments about weight is the #1 cause of bullying in schools for kids and adolescents. So it's the #1 reason why kids are being bullied. And like you said, it happens in families, it happens, from your family members, immediate in the home, but also relatives, cousins, aunts, uncles, peers even. There's peer-based teasing, weight-based teasing, comments about weight, negative weight, derogatory comments, making fun of people. There's fat jokes everywhere in the media. I mean, this is just everywhere. And it's really hard because, and I agree, because it's so prevalent everywhere you go, it has such negative consequences on every aspect of a person's life.
True.
On their mental health, on their physical health. There's tons of research now that has lots of impacts on their quality of life. It affects people's self-esteem. It has increased risk of anxiety, depressive symptoms, suicidal ideation, disordered eating. It really is at the root cause of so many things. And like you alluded to so well, is that we need to move past education. Education is one thing, but when you think about this on a ladder of impact, education is at the lowest level of impact. If you just do educational initiatives, talking about things, awareness is certainly important, but we need more upstream approaches, getting government, getting policies in place, policies in schools for anti-bullying policies, things that really, really change people's behaviors is really when you get at the top of the ladder if you're taking a public health approach to things. And I think it's just so important to address those things so they have trickle-down effects. And it's not only thinking about awareness and education. We do know quite a bit about this already, but we need those higher, more impactful interventions to make a difference at so many different levels.
Thank you, Dr. Angela, for mentioning about that, how these all bullying and the societal comments coming from different societies domains, neither it's a school or your family or your friends, or even you could be your workplace, where you've been stigmatized. There are so many things to talk about, but one of the things which Dr. Julie has mentioned about the self-esteem, and if it brings your self-esteem low and then it starts having the anxiety and stress and all other stuff, let's talk about the mental health. And how do you see the children with obesity who face these kind of challenges? Even with the society, within the family, they feel guilt to not tell them. They've been body shamed at school, and they feel less confident. How to tackle that one and how it impacts their mental health?
Well, it's impacting so many things. I mean, their relationship with their friends, with the teachers, with even going to practice, a sport after school, or, it's affecting everything, even grades, because some kids stop believing in themselves. So the approach that we want to address, it's more than 50%. So 1 out of 2, and that's our data. I know that some other groups have even higher impacts, but at least 50% have an impact on their self-esteem. So it's always, the first thing that we address when we get to know them on the first consultation, to evaluate how it's going to be difficult to rebuild that self-esteem, and the way to do this, and it's very effective, it's to focus on also the school project and what is that kid would like to do in his life, and to build on little success, little challenges. And once you have one that is reached, then you build on that success. And to do that, you need to see them very often, like every 4 to 6 weeks. So it's a lot of, engagement from the caregivers, but also from the family, to rebuild, something that might have been broken in one day. So, and it's gonna last forever. You never forget. I've been living myself with obesity since I'm 1 year old, and I'm 51, and I still remember when the others were looking at me and I was looking different, So I do not doubt about myself today, but, I still have, that sadness inside
That's
of me.
internal
And I
stigma.
remember that look, yeah. So it stays forever.
It stays with the rest of your life with you, because from psychological point of view, I would like Dr. Sanjeev to add on this one. What I understood is that because whatever the traumas happens at your childhood, no matter what reasons are behind that, it's a society's involvement, your personal choices, like people are saying personal choices, or it happens because of families, but it stays with you throughout your life, and it impacts your adulthood. In context of obesity, Dr. Sanjeev, would you like to add something that if some individuals at their childhood, they were body shamed and bullied for having the excess fat, or you can say that a bigger bodies, size in terms of size, and they were shamed for that, how it impacts their mental health, and reconnecting it back to the obesity, how mental health further aggravates the severity of the obesity?
Yeah, so you covered three big themes there. So maybe I'll start with one that, these traumatic experiences, weight stigma, bullying, the, negative interactions during childhood, definitely childhood trauma for sure increases the risk of adult who are living with obesity, the risk of living with obesity as an adult. So there are meta-analyses that have shown that. And if I go in a more nuanced way, we also know that there are the ACEs study, the early childhood adverse childhood experiences studies that were done, which are pivotal trials, large population studies that show that early childhood adversity, actually increased the risk of many physical health conditions, and they included obesity in that, but also obviously many mental health conditions like depression, anxiety, post-traumatic stress, and so on. So we have large population data that actually supports this kind of convergence of kind of increasing risk of kind of continuing, perpetuating, or increasing the risk of obesity and the mental health complications related to it, which many of the panelists have already summarized some of the mental health complications. You asked another question about what about the impacts of this vicious cycle of kind of mental health and obesity? Well, if you're someone who's been living with obesity since early childhood or as an adolescent and then as an adult, and you develop depression, anxiety, or some of the disordered eating that happens as a result of some of these pathways as well, this is only going to complicate response to obesity treatment if it's not addressed. So people will continue to, in disordered eating, it can contribute to overconsumption and kind of weight gain and health issues. Depression, anxiety might lead to disengagement in care, difficulties keeping on track with things, self-doubt, and low self-esteem. So that can be problematic. And then there may be treatments that are initiated for these mental health complications. Sometimes that make it more complicated to maintain weight loss, and may have weight regain as a result. But I'll also say that biologically, we know for people who maybe weren't living with obesity as a child or adolescent, but developed it later on as a teenager or as an adult, after they develop mental health complications. So if you have depression, anxiety, depression or mood disorder, and you develop obesity after the onset of a mood disorder, independent of medications, it makes your mood disorder more resistant to treatment. And so we have to think about this bidirectional relationship. And that, again, we want to be able to intervene early with obesity to be able to help all health consequences and overall health for our patients. So it's really this kind of bidirectional relationship, and why it's so important to recognize holistically early on someone's impact on mental health in terms of obesity management.
Thank you, Dr. Sanjeev, for mentioning all the different approaches which can be used to treat the complex cases of individuals who were stigmatized at one stage of their life, let's say childhood, and then they suffer throughout their life, and they lived with that guilt, you know. So it's very unfortunate. So just to add on to that, I would like to ask the question to Jennifer. Would you like to highlight a little bit about your experiences dealing with individuals with weight stigma in your healthcare setting? And how do you approach it?
Yeah.
Yeah.
I mean, I think that, everybody has kind of alluded to some of the horrific experiences that both children and adults have lived with or experienced. I think in my career, and I've unfortunately seen quite a lot of stigma that has occurred in the healthcare setting. I think it starts just in going to see your doctor, looking at the size of the chairs, for example, that might be in the waiting room, the magazines that are in those waiting rooms. Are they showing people? Oftentimes, the magazines are highlighting, somebody's body or losing weight. Like right now, getting ready for the summer, there's always messages around, shed 30 pounds before the summer, get beach body ready. I think kids see that. Adults are, might have that around the house, or again, it just perpetuates that when we see it in the healthcare system. All the way to, even in the doctor's office, and whether it's in a hospital, in an outpatient setting, in your family doctor's office, the exam room table may not be appropriate in terms of the size. It might be very difficult to to have access to certain equipment. I'm reminded by something I saw not too long ago. As a patient going to see my own doctor, I saw this happening where a physician assistant was coming around to people in the waiting room with one of those blood pressure carts that you could roll, and they were taking people's blood pressure measurements in the waiting room. I'm assuming as a way of trying to help speed up the appointment times. But I don't think that people understood the amount of bias or stigma that was causing, because people, again, that's not a private setting. Second, there was people that you feel uncomfortable. The blood pressure cuffs didn't fit certain people. You have to take off your jacket in order to for them to take a blood pressure reading. I think that health professionals in general need to recognize some of the harmful stigma and bias that can lead to. And there's stories and stories, and I know, like Angela, this is her area of work, of looking at all the healthcare stigma that exists. But as much as I want to say things are getting better, and to a degree they are, I think we all kind of can see aspects of what is happening in the healthcare system, and people being denied treatment or care because of their size or their weight, the equipment not being appropriate for people in larger body sizes, healthcare professionals just not being trained, not knowing what to say or how to say things. So there's a lot. I could go on, but I'll pass it back to you, Muhammad, because I know there's other aspects we could share on this.
Thank you so much, Jennifer. I agree the way you mentioned that there is one component of healthcare stigma inside the healthcare facilities, where the people are being stigmatized by healthcare personnel. That is also, let's not forget that that's also one of the components where there's a lack of education or training for healthcare professionals. They don't know how to handle these situations and talk to patients or people who are having these kind of issues, right? And that is one component. And further, you mentioned that the accessibility of the treatment, it can come to the equipment, and it also can come to the cost, you know. Obesity is not recognized as a disease yet inside Canada. For my information, like thanks to the Alberta government, they have recognized it recently, the obesity as a chronic disease. And we must advocate for it to let the policymaker know that obesity is a disease and it should be treated in the same way like other diseases are being treated, like diabetes, hypertension, you know. And coming back to the same point which Dr. Sanjeev mentioned, that obesity is just not only one disease, it is contributing and impacting 200 other diseases, right? And eventually it leads to the cascade and, you know, a lot of contributions towards the healthcare system in terms of cost, accessibility. So just to add on to that, Dr. Murray, would you like to talk about the service, you know, which is being provided to individuals living with obesity and diabetes inside our healthcare setting, how we can make it more equitable?
More what? More?
More equitable, equity, health equity.
Yes.
So that it's accessible for everybody.
Yeah, I mean, doctors and nurses and allied health professionals, they lived in our culture, so they reflect what our culture is. And yes, there is stigma towards people with excess weight, you know. It's true also that due to excess weight, when it reaches certain levels and values, there is an impact in physical performance, okay? And only very specialized clinics have the necessary equipment to welcome these persons. So it is a struggle for them to go to their appointments, to go into a small room to be examined with the bed not prepared for them, or already mentioned by Jennifer, the non-adequate chairs in the waiting room, but there's a lot more education to be provided to the healthcare system, not to contribute to the stigma that makes one ashamed, that makes one more avoidant to look for the right services that they are very much in need of. The exceptions probably being if you go to a endocrinology obese clinic, very specialized one, or bariatric surgery clinics, because then the area is adapted to them. But attitude of the people, even in these clinics, sometimes it's totally non-acceptable or appropriate, which contributes to this feeling of you know, you feel that you're not desirable in the area, so you are excluded because of the attitudes, and you don't need to say things, just the way you behave with them, making them feeling guilty, which is non-acceptable.
Thank you for highlighting this. I think Dr. Angela has something to say about the same issue on EDI and then healthcare setting stigmas. Please.
Sure. Yeah, I was just going to add to what you're saying. Definitely, there's problems with the healthcare system in terms of building the environment that supports safely and welcomes people of all shapes and sizes. So definitely the healthcare system that you've highlighted and that Jen so nicely highlighted is the importance of understanding our built environment and how our resources that we have in the healthcare system and how people access the healthcare system is really important to address. You know, but I think healthcare system is one thing that definitely has a say and has an influence in equity. But when you think about equity, we also think about social determinants of health, and those factors being factors that people are born into. We're born into these social determinants of health that we have since we're born, and those influence our access to, our feasibility to, our so many things that we're able to access the environment. But when we think about that, we think about people who are underrepresented. So we think about disparities that exist in our society, people who live in rural and remote communities, who don't have access to evidence-based services and treatment, multidisciplinary healthcare teams, people who are trained in obesity care and support. So I think it really goes beyond just the healthcare system, but also where you live and vicinity to healthcare services and understanding of obesity as a complex condition that, can use support from a multidisciplinary team who has evidence-based related treatment and supports. So I think it all goes together. There's so many things about equity that are so important that influence access to treatment. So I think it's important to think about all those things and how they play into access to care.
If I may add quickly a very important factor that was not mentioned so far, access, equity will rely also on dollars. So without resources, the good people across Canada that can, as us, that can advocate for change to improve the access and the equity won't be able to reach that point without, dollars. We're living in America, and that's a very big issue. We need money to be offering the best models. And that will be a very challenging issue for Obesity Canada and his leader over the next few years.
Thank you.
And Julie, you're also speaking about government support as opposed to just income from individuals out of our own pockets. Yeah.
Thank you. Thank you for mentioning this one. It brings me back to the thing that last week I was reading about on March 4th, the obesity World Obesity Federation, they release their atlas every year. So I was reading that, and one of the narrative they want to put forward was that it's not the individuals, it's a system which needs to be changed, right? It could be your social system, it could be your health system, your food system, your media, there are a lot of different systems which need to be changed rather than putting the responsibility on individuals first. First, we need to focus, we need to shift our focus towards the system. So how those systems can be changed? Does any of you has something to say about that? How can we actually, yes, please, how can we actually ask the policymakers,
Yeah, so I've been doing that for quite a few years, especially in Quebec. And it's the political view, it's the political system, relying on a 4-year basis. It's awful. I mean, for a chronic disease that lasts forever, how you will convince a politician to change his mind, his fat phobia beliefs, and go for it close to an election. I mean, no way. He has 50% of the population that will be against him. So it's not a sexy talk, to have for politician. So from my experience, and it's relatively small compared to what Obesity Canada is facing with the Canadian government and every provinces, but my experience is that they have a short vision. If I compare to Denmark, where I've been invited a few times to discuss with different level of government, regional, very local, provincial, and also federal government, what I see is that they have that culture of long-term health projects that cannot be moved by any politician, any party. And this is a long view, long-lasting project that everybody's agreeing on, is to focus on health determinants and grow this project toward times and at every ages. As an example, the architect responsible for the city in Copenhagen, she has decided with the health minister and also the regionals to invest in public pensions. Why? Because they want elderly to be able to walk, sit, and make sure that they can go outside without fearing that they might having trouble walking for a long distance. So they all agree on that, and that is not movable over the time by any politician. So I think the challenge will be very important as Canada is wide and very diverse and rural versus cities. We have to start a change in the culture, and that starts early, you know. So I think that the next year will be very important to advocate for that change.
Yes, thank you. Thank you, Dr. Julie.
Yeah, you bring up some really important points. I had the privilege of participating in a program called Science Needs Parliament. And that's a program where we got to speak with various members of parliament and, you know, kind of try and get a feel for the parliamentary system and stuff. And what you're saying really resonates, because a lot of the times when I was meeting with some of the parliamentarians and things, a lot of the question is, well, how is me advocating for this going to get me votes? Like, how am I going to get votes, right? How is this important to my constituents? Which is like, is a little bit unfortunate, because sometimes what might be important or might be the most prevalent issues for the constituents there might be other things also, that such as this advocacy for better environments, or built environments, in other words, to be able to promote activity and to promote these sort of behaviors and lifestyle that are not as prevalent as or as sexy as some other issues. So it really is I think it's a challenge to try and send the message to the constituents, the people who are voting, and to everyone to collectively try and advocate for these type of shifts in terms of our society and our initiatives.
It seems like, yeah, priorities are so important, and clearly priority is not high for these types of important discussions. And I think both of you bring up such important points, especially about the long-term vision. And something that I want to bring into this conversation too, that Sanjeev had mentioned earlier, and I think Jennifer also did, is that we also have to work on undoing a lot of the harm that has happened for a long time. Because unfortunately, you know, public health and the focus on obesity has also actually caused harm, unintentionally, of course. We have to give credit to, you know, people who are advocating for proper change and being able to promote health and, you know, reduce risk of chronic disease and associated chronic illnesses. We understand that the intentions there were good, but we still have to do a lot of work of undoing that harm, because a lot of that public health focus on weight, the focus on calories in, calories out, has actually caused a lot of the harms that we're trying to undo now. And that caused actually quite a bit of stigma too. So as much as I think we definitely need top-down approaches and upstream approaches, and governments involved in policies, we have to just really keep in mind that we have to be careful in the way we frame things, and we have to be careful in the way that we discuss things, so that we're not actually putting even more harm and try not to undo the harm that we've already done. You know, it's really complex. We're not in an easy time to be able to do that, but I just want to mention that in the conversation, that we need to be sensitive about these things too, because a lot of things we still have to undo before we could still do more good.
I like this thing, actually. I like that Jennifer has mentioned this thing, which, yes, she's there. And I just want to say something that Jennifer has mentioned earlier, that we need to undo things and then do again. We need to unlearn and learn again, you know? So Jennifer, would you like to add, please?
Yeah, I just wanted to kind of build on what Julie was saying around but changing the system, right? And you mentioned it too, Muhammad, that we don't need to change people, we need to change the system. And you know, as much as we've talked about that importance of the top level, I'm reminded about all the work, and I'm again just putting a plug in for Obesity Canada, but for any organization that is really helping to support people with lived experience. I think the challenge that we tend to see is that, you know, right now this is coming, a lot of the push and advocacy is coming from researchers and clinicians and, you know, people with a very passion and empathy component, but change doesn't happen at the political level unless it's coming from the public. And if we have a public system and people who have been stigmatized and discriminated against and oppressed really most of their life, it's going to be very difficult for them to kind of rise up and say, this is unacceptable and we need change. And if we're trying to make that voice, on a political stage, I think we need to have resources and supports for people with those lived experiences. I'm reminded all the time about the saying, nothing about us without us. And I think Obesity Canada and other organizations have done a phenomenal job in leading the way around having that patient or that lived experience voice. Nothing we do as clinicians or researchers or policy level should ever be done without the lived story. And I really do believe that that's a place that can make a huge impact. So I don't know if Sanjeev, you want to talk about it, but I know that Obesity Canada's website has letter campaigns that people can actually fill out, and it goes directly to their members of parliament. These are all little things, I think, from the grassroots that can make a huge difference in making those changes long term.
Yeah, I was just going to comment on this discussion. This is a very timely discussion. It's a discussion, personally for me, and I'll share in a moment why this is highly relevant. But for Obesity Canada, this is on our strategic mission of, the multi-pronged approach. I think, as Jennifer said, Obesity Canada has had its roots in research and science as a network of bringing clinicians and scientists and researchers together. But over the last, I would say, like 10-year decade or so, a little bit more, has really leaned into lived experience being the third pillar to this. And that is from learning together in lived experience. One of the few conferences I attend in every year, or events where lived experience is so prominent and part of every kind of discussion, from research to bedside to all the way to clinical care policy. In co-creating education, and then more importantly, to connecting people for support, but also giving them opportunities to activate people to really, and I use the word activate rather than activist, because it's really to create that energy from the ground up, and the tools like advocacy letters that are standardized that people can use, how to speak to employers and advocate for insurance individually, which really pushes private and public kind of inertia in a different direction. I'll just say, though, my earlier comment, why I'm passionate about this. I actually, being a psychiatrist from my training from med school all the way to where I am now, in mental health, I've seen a very significant kind of trend, and there are many parallels, not identical, but many parallels to where we are in obesity at this inflection point. If you think back to 25 years ago in mental health, there was a ton of stigma. People suffered in silence. People were marginalized, and people still are. But there have been significant improvements in many conditions related to mental health. And, people speak openly about this. Children, youth, speak openly about this and have conversations, which would never have happened in 1999, for example, or 2000, right? And how did that happen? It happened because, one, there was science and research about treatments and our understanding of mental health, that it wasn't about weakness or behavior. It happened because the treatments became available, and so we had hope and something to offer. Patients demanded it, and we're like, why can't we get access, and why are we not getting treated? And then governments came up with a federal strategy. The Mental Health Commission of Canada was formed actually in 2012 after a mental health strategy that came together and created a policy, to the earlier comments, that despite change in government, these were the commitments that were made, and that would then start to translate to provinces on how they would do this, and start to get tied to federal to provincial funding for mental health services. Still underfunded, still lots of work to do, but significant movement in how that could be established. And I do think we need a multi-pronged approach. I do think we need a national obesity strategy informed by research, experts' lived experience, that comes together, creates, and people say it's a framework. We know what we need to do. We do, but we need to cement it nationally so that we can then agree on this and start to work on how this permeates through all parts of healthcare. as well. And I'll say the last thing is the interesting comment about Denmark. We are actually more fragmented than Denmark and more complex. But people may be aware that the Lighthouse Project in Nova Scotia, which focused on childhood obesity and is going to focus on adult obesity, was Denmark industry. And you can say what you will about the pros and cons of industry, government, working together to create funds, to create innovative models and approaches to get upstream, and they're continuing to do that work. And I understand Quebec is also on the radar for this as well. So like these partnerships are important to test and push the system, but to make sure we evaluate them carefully as well. Yeah.
I 100% agree with Sanjeev about that, and it's also encouraged by WHO policies to work with every partners, including the industry, if we want to solve this epidemic. And I think the national strategy is very important in obesity, because I'll share with you how strong the roots of stigmas are at the provincial levels. With Obesity Matters and the French chapter in Quebec, we organized a few activities over the past year with the National Assembly, and we were there last week. And despite all the efforts that were made to reach, 130-ish deputies, we only had 4 who accepted to share with us about obesity. Those 4 were amazing, and they they really will be great ambassadors. But at the same time, it's very discouraging to see how strong are the roots, against, sharing patients' lived experience, because that was the main reason for our visit with them. So this has to be addressed, just like mental health issues at the national level, and really ask. It's about time that we have a national commission on obesity and actions that will last for a long time.
Thank you for highlighting this, all the different factors which can contribute towards, improving the policies and making the change in the society. So just to summarize it, I just understood that it's more like a human thing, it's deeply human things. And when I was reading the World Obesity Federation Atlas, and one of the things they mentioned that it's a collective call for action. It's not individuals, like you mentioned that there are individuals from government policies which need to be included. And most importantly, when we are advocating for the change, that advocating for the change should comes from the lived experiences. There should be the partnership between the healthcare personnel and the patients, and call for the collective actions. Thank you so much for highlighting all these different components of obesity care in Canada. So just to summarize, thank you to all our panelists for their insight on obesity. And what we understood today is obesity is a chronic disease. It's not a personal choice, and it's not the personal responsibility. And thank you all of you for showing us today for this vital conversation. Now we are going to open for the question and answer session with the audiences, both in person and virtually. Thank you. Any questions?
Thanks, Muhammad Ilyas. I'll just mention, if anyone, those of you joining us on Zoom, if you have any comments, questions, pop those into the chat. We can read them out. Anyone here in the space, just raise your hand. We'll bring a microphone over. Do you have any questions? Okay, we've got one.
Thank you so much for everyone. That was a very insightful and timely discussion. I have a question for Dr. Alberga and Dr. St-Pierre regarding childhood obesity. Especially we know that cultural and generational influences modify our behaviors. For example, when I was a child, I was always told that throwing away food is a crime. And so instead of stopping when I'm feeling full, I continue to eat everything on my plate. And again, seeking comfort in food, especially when you're feeling sad and or angry, you just comfort yourself with food. And these kind of unhealthy behaviors affect children a lot, and especially when they're going to their adulthood, and also now a lot of children undergoing bariatric surgery at their adolescence. So there are treatments available, but that kind of unhealthy behaviors and habits, we need to address them. And what are your experience related to this, and what kind of suggestions you suggest for issues like this? Thank you.
Thank you for your question. You're pointing out something very important. And if you're a clinician working with, young patients, you have to be trained and use interdisciplinary approaches to make sure that you address everything that you said. It's part of what we do as a first meeting with the patient and his family. It takes 3 hours to address, not everything, but the important things that we have to address in terms of social determinants, but also screen time, sleep, eating behaviors, and also cultural backgrounds. And it varies so different from one family to another, that every one is unique. And yeah, this is something that we will use different techniques like motivational interviewing to address that with the parents. Sometimes we'll have to ask the kid to leave the room and tell the parent, did you know that science have evolved and that we are having a different approach in terms of eating with kids? And we would let you know that now we do not ask a child to finish his plate, as an example. And the nutritionist or the dietitian that will follow after me, she will have, it's going to be super leverage to give more advice, because the physician just said it's important that you consider modifying the way you act at the table with your child. And she's going to have a very nice interview then to go deeper into that behavior and modify it with the parents. So it's really the interdisciplinary approach, considering all the social determinants, and also what you have pointed out, the behaviors, the uniqueness of every child, that will, remove guilt and work on successes.
If I could just add to that, thank you for your important question. Also a timely question too, considering the Canadian Pediatric Obesity Guidelines just came out this week. So it's an important conversation to have, and thank you for the opportunity to be able to talk a little bit more about them. And I just want to echo what Julie's mentioning. I think the importance of really doing thorough screening, understanding, what's going on, what are the living conditions, social determinants of health, understanding that, and the piece of culture. So you bring up culture and importance of values and preferences to families. And that's something that really came out strongly in the Canadian Pediatric Obesity Guidelines that were just published, is the importance of valuing and doing shared decision-making between patients, kids, teens, families, and their healthcare provider, where as opposed to just a didactic, the healthcare provider knows best kind of approach, which of course, being well-trained and having good evidence-based data to guide decisions helps, but having that understanding of what's important to you as a family. What are some things that you value? What are important? What are your outcomes of interest? What really matters to you? And having those shared discussions with healthcare providers is so crucial. And that's probably the most important piece. One of the most important pieces that came out from the guidelines this week is prioritizing that and understanding what matters to them and focusing on that. So those outcomes that typically really matter to patients and families are things like quality of life, anxiety, depression, outcomes of interest that are important to them, and working with that and what's currently of evidence that's also available there to help guide those shared decision making. Just want to add that.
Thank you, Dr. Angela. And it's a very good question, Anjali. I just want to add something on it before we move to the next question. It's a thing about the children needs. I like the term you mentioned, the relationship between healthcare providers and the family and the children's. And it brings back the psychology point of view, that how relational psychology actually improve the patient care, right, in healthcare setting. So being a clinician, I have a question for both of you actually, Dr. Julie and Jennifer. Would you like to highlight something on this one, that how relational psychology between the healthcare professional and the people who are suffering with obesity, especially the children and their families, how do you tackle those issues and how it's important, for better care?
It is, mandatory that you address, psychological health or mental health at the first appointment, but it will not be the first, topic that we'll jump in. We'll keep that for the end of the interview, because you need to address, other things before, as food insecurity. It is so important, and kids are getting poorer and poorer across Canada, and this is a very sad fact. So before, you have to understand, how's the family, running? Is there someone at home when they come back? All right. So at the end, you can ask, are you sad? But before, you have to better know what's happening in that family before you address the mental health. But it's mandatory that every first time that we see a family, it's part of the evaluation. And it's also in concordance with what we have published this week. Also, it's part of it. It's really important.
It's really important and mandatory. Thank you.
Yeah,
Yes,
and
Jennifer?
I think it's a fantastic discussion. And if I can kind of add to it, as from a dietitian standpoint, and I would say that this would be any clinician, one of the things that I'm often reminded of is, whether I'm talking to family members or children or adults, I think I end up starting a lot of the conversation with an apology. As a dietitian, I recognize that coming to see a provider, especially talking about food, that is so incredibly personal. It can feel very, I like to call it our bubble, and it can be very uncomfortable for a lot of people. So I like to apologize a lot of times on behalf of either my profession or the healthcare system, in terms of any past experiences they may have had. I like to offer a space, a very safe space, for people to recognize that I'm not here to judge. I'm not here to tell people what to do. I think it's already been very eloquently said about that partnership with families and children and youth and adults, that, you are the expert in your life, and I want to help support whatever those outcome or values and preferences that are really important to you. So I know that my biggest thing is, again, that apology piece, setting a stage for safe dialogue, and then listening. I think probably the most important thing as a healthcare provider is to just offer a place where people feel heard, and we don't have to come up with answers yet. We don't have to look at everything quite yet. We can just have that place for people to have an opportunity to talk, and for us to just sit back and listen. I think that has been a life-changing experience, both for me as a provider and the relationship that I have had with a lot of my clients and patients.
Jennifer's approach is amazing. I love the apology approach. If I may add just one extra point, something that I forgot to mention, something that I like to do every new appointment I have with a new family is to start with, once I ask the permission to discuss the matter of the consultation. Then I start with, did you know that it's not your fault? And this is, a game changer in the discussion, because 50% of my patient will start to cry, but to say thank you for saying that. And this is repetitive over 20 years, 1 out of 2, either the parent or the child or the teen will start to cry and say thank you. So the apologize, I think I'll start doing that as well. By the way, thank you. But you see, that's amazing. It's nice to share between us, but saying it's not your fault is something very, very painful for the whole team.
I mean, fantastic for these two things which I just listened, and I realized that we should do it in our every aspects of the life, not only these practicing, even in our daily life, because one of the feeling which is important in life is to love and to be loved, to be listened, and thank you, Jennifer, for mentioning this, that we need to have an open conversation with our patients and sit back and listen to them. So that, and thanks, Dr. Julie, for highlighting that we should not blame them and let them speak about it, break the ice, so that their expectations need to be met, eventually by us clinicians or healthcare facilitators. Thank you so much. Thank you, Anjali, for such an amazing question which led to this discussion. So we have another question?
Yes, ready.
Thank you.
I can ask my question. Okay, I'd like to build upon that question. And I am curious about the role of, you're mentioning culture and habits around food, and I'm curious about the role of culinary culture in all this. In that culinary culture is not just what I eat, but it is how I eat, why I eat. It's the values associated with this. And my question is coming from a point of a culinary professional. So I worked for 20 years as a chef, and then I taught culinary school for 12 years. So in all this, like there's the culinary world that it feels like hasn't been mentioned at all. And I'm kind of curious, well, what would the role of culinary culture be in all this? And what would the role of a culinary professional be in all this?
Oh, I love this question. Can I answer part of it? I think one of the most important things when it comes to food aspect, and thank you for asking these questions and putting a big plug in for the importance of culinary and food. Food is meant to be enjoyed. And, we live a very busy life nowadays, and food tends to be almost a nuisance in a lot of people's lives. It tends to be very polarized as well. And food is there for, yes, it's there for nourishment, but nourishment also means, body, mind, and soul. We need to encourage kids and families to cook together, learn how to experiment with different flavors and different foods, and eat together and enjoy things together. And I think bringing in the world of culinary food is so important, because we have such amazing food nowadays. But yet, a lot of times, especially in the lens of obesity, it tends to be demonized. And I think that's a big piece we really want to break down. We want to, again, unlearn and relearn that piece. And I think there's a lot of partnerships that can be had there. But we need to involve people and the family and the food industry and the chefs and everybody involved in the production process of food, so that we get back to enjoying food and not putting it into a pedestal of good versus bad or healthy versus unhealthy.
Thank you.
Yeah, I just wanted to add to that. I completely agree with what Jennifer has said. Especially in the lens of obesity, I think it's common to try to start to demonize food. And I think it's really important to build those positive relationships with food and promote a culture where as Jennifer said, you can sit around, eat at the table, enjoy the food that you're having, teach like even just fundamental skills in terms of food preparation and food cooking and things like that should be viewed positively rather than, for example, it's a chore that I have to do because I have so little time to be able to do all this and like let's just shove food in my mouth so that I can just like get going with my day. Of course there's going to be days like that, but to promote a culture where we tend to have more of a positive relationship with the food that we're being offered and the food that we're eating rather than to demonize it, I think is a very important aspect and one that I think the culinary arts can very much contribute to.
Well, if I was not a clinician, I would love to be a chef. Okay, so I have a very special relation to food. Okay, I was raised in Saguenay-Lac-Saint-Jean. You eat as much as you can, but just good food. So you know what I mean. So it's important because we eat with our eyes, with our smell. All the senses are important, and what Jennifer pointed out is that we don't want to demonize anything anymore. But there are things, working with chef, I did work with chef to approach that with kids. It's maybe just how you serve, over the time a meal. It can be prepared, very gastronomic menu and served on a timeline that will make maybe your client feel their satiety and will enjoy as much and will maybe pay even more, to get this experience with animation. And, so there's so many things that we could do with the art of the chef. And this is something, that we want to definitely to address in the future years. I've been asked by l'ITHQ a few times recently to meet with them and also to develop some projects, but there's only 24 hours in a day, so please jump in and get involved and please develop those projects.
I love this question, and I am not a dietitian by training, but I am a kinesiologist. I'm a recovering kinesiologist. So I like how Jen's approach of like apologizing first. I'm also going to apologize because we tend to also not have a great reputation either, kinesiology wise too. So I'd like to just take this opportunity to mention that something that often is not talked about too is how exercise and physical activity is also framed. And how I love this approach of like non-demonizing food. We should also not demonize activity and movement and joy of movement and joy of walking. When we think about children, they're great examples. They're naturally active beings. I have a 3-year-old and a 5-year-old, and they're constantly moving and they love just moving their bodies in space. And we can learn a lot from children too in that approach of not demonizing things, whether that's food, culinary approaches, but also just movement and activity and just being in our bodies and the ability to be able to do things that we like to do. So I think I love your question because it could apply to so many different disciplines and fields. And I think we need to think critically and creatively about how we can build spaces and promote things that we love and enjoy, that we want to provide happiness associated with, as opposed to demonizing things like food and activity and other things that bring us so much joy.
I mean, thank you so much. I'm suddenly craving now. So the thing is, I had some personal connection with Dr. Jose. He used to say, a piece of a cake, walk in the park, So the thing is moving and eating and moving. Dr. Murray, do you have opinion on that? Then we have the questions in the chatting.
Tell me about the opinion on what? On the piece of cake or the walk in the park?
Both of them.
Could you present the question directly, because I don't want to answer besides,
Yeah, I mean, what I wanted to say is that bringing back to the discussion which we earlier started, that eat less and move more. So how it actually relates with our physical health in terms of obesity,
Yeah, for sure. Looking in our present culture, that I alluded at the beginning, saying there has been so much transformation in our community in terms of society, in terms of how we now control the environment to an extent that was never reached before, in terms of transportation, availability of food, a lot of enjoyment, access to computers where you spend hours and hours seated. All of this contributes to this, and without necessarily we being sensitive to it, without necessarily choosing bad habits, we are inserted into this culture, okay? So there is a need, without being ashamed, feeling guilty, but there is a need to be more proactive regarding our health, okay? And this applies to any of us. I remember at the beginning of my career, 30 years ago or so, I was in a nutrition lab dedicated to obesity. And some participants in research projects used to say, for you, it's not to me, but to one of my supervisors, saying, for you, it's easy because you're not obese. Well, the answer of this colleague of mine that is now retired is that, me too, I make efforts, I'm self-conscious of what I eat. I have to be more proactive to take care of my health. And I'm not saying this in a negative perspective, but just is a kind of self-assertion. Because, unfortunately, we are human, and it's so easy to lose balance in all aspects of our lives. Some of them we are preconditioned. We discussed previously about these determinants of life, the way we were raised, so many factors. We are so complex as human persons. But I think now that the environment is less favorable into maintaining a healthy weight. I'm not talking about obesity. I'm not using BMI values. I'm just saying a healthy weight that can vary from one person to the other. I think we have to be more self-conscious and be more proactive in our maintenance of health, especially because we have greater longevity, greater life expectancy. And as a consequence, we can prevent some of the decline in functional capacity that accompanies aging so much. And there is ways of doing things to make it more attractive, our messages, to really counteract the message that we receive in so many ads when they talk about food. They don't present good quality foods, So we have to have an alternative, and because when you intervene for your own self, you regain some of the confidence that we miss sometimes. At the beginning, any change in our habits requires an effort, and the person needs to be supported. But if we continue in this direction, there will be benefits, both physically as well as psychologically, for every person.
Thank you so much. Thank you, Dr. Mar. Yes, Dr. Julie.
I agree with Jose, and something that I find very powerful to use with my patients. I do not share necessarily, about my disease, and I get the comment as you that I cannot understand because I don't look like I'm suffering from obesity. But I'm not sharing that. But just saying to a mother or a single father, oh, I find it difficult myself to go to the grocery store and shop, and dig for, different things for the kids. And, that is so powerful because they rely on, wow, this is focusing on health habits instead of disease habits, sharing something that it's tough to address on a day-to-day basis, but focus on healthier life instead of the disease.
Thank you. Thank you for highlighting this. Doug, do we have another question?
Excuse me, we do have a question. on Zoom from Kayla. Kayla, I wondered if you wanted to turn on your microphone and ask your question. Or your camera.
Hey, oh here, I'll just lower my hand. I have a question for basically anyone who wants to answer about how the effects of social media have affected especially like the younger population in terms of tackling misinformation, but also self-esteem in terms of, you know, living with obesity. That's my question.
Do you want
Anyone
to
can
start?
go, no problem.
Angela, you're free. I'll be short, okay? But there's a few studies starting, among adolescents, female especially, but it's also true for male adolescents. They push very negative, messages, and that really does have a very bad effect on those kids. So something that, they have started to develop, it's the approach clinically to address that with, first to share about the potential harm of this, and as we always look at the number of hours per week or per day that the adolescent is consuming, and you might be surprised or not, but it's 8 to 9 hours per day per adolescent. So it's a lot. So that's the average that we see. So let's say maybe you could, restrict yourself to 1 hour of Insta, TikTok, and whatever. Maybe you could just remove it if it already has a bad side effect on you, so you will be less tempted to look at it. But definitely the messages are very, very bad. The influencers are very popular. They are numerous as well. So it is just a starting area of studies. But already we have very negative effects that are on teen, especially females.
Thank you. Thank you. So thank you for your great question. And this is such a loaded question. I didn't know which path to really start with, but maybe let me just start a little bit about what we know about media in general. So we know from decades of research in psychology that media is one of the #1 risk factors for body image dissatisfaction and disordered eating patterns and low self-esteem and not feeling good about our bodies. So we already know that from decades of literature. And that's when media was magazines and posters and pamphlets and movies and, radio and stuff like that. And now we've evolved and we've changed. We still have some of that, but we still also have social media now. And like Julie alluded to, there's not only just the effects of just being exposed to more screen time, but the content of the screen also really matters. So what people are being exposed to. So if there's messaging that are mostly about thin ideal internalization and promoting just thin, small bodies and not promoting diversity of shapes and sizes and people in different shapes and sizes performing regular, healthy type activities, that exposure, that representation really matters. And when there isn't enough of that exposure of diversity and healthy representation of different bodies and different shapes and sizes, that could also be unhelpful and harmful in terms of messaging for teens and young adults. So if I can just maybe conclude with a last little message about this, about social media, is choose your social media wisely. Thankfully, we do have at least a little bit of control of what we're being exposed to. We can choose what influencers we watch, what we follow. Sometimes not. Sometimes ads are being thrown in our face. And unfortunately, we have to be careful of that too, because that could still affect our mental health and how we feel about ourselves. But at least you can try to be careful in what you're choosing. And Julie alluded to that too, is if you're starting to feel negatively about yourself, pay attention to those messages and those reactions to try to choose platforms that really follow more with your values and can help you feel better about lots of different things in your life. I know it's challenging, but at least trying to be really thoughtful about what you're being exposed to can really help, and what children are being exposed to too. I'm as a parent too, so I wear two hats, researcher, also parent. And I'm so fearful of those kinds of things too. I don't want my kids to be even exposed to those things. We'll get there when we get there, but if anyone else wants to add.
I think Jennifer has
Sure.
something to say.
You know, yeah, it just struck me when you were saying that, Angela, about some of the things that we can do individually. But then I'm reminded, I'm going to be a little bit controversial here, but I'm also reminded that we need to change the system, right? Not people. And so I do think that there's perhaps some responsibility at the industry levels or at these company levels in terms of they know exactly what algorithms are built behind these systems. And people, don't kid yourself, everything that we're seeing on social media, even when they're being promoted by influencers, they might have had some really good intentions to start, but a lot of it comes down to money. And so I'm mindful of the fact that, yes, I think individually we can do a small part of our own, but there needs to be a system approach too. And so I know there's lots of discussions around whether or not there should be some sort of filters or something from a system level that can help prevent this from happening. I don't know what the right answer is. That's why I'm saying this is controversial. But I do think it's something for us to just consider that this shouldn't just be put on us individually or people. It really does need to take that whole collective. And I think that these companies do have a responsibility to make sure that they're not causing more harm.
Oh, I just want to echo what Jen's saying. Absolutely. I think this is something that's so important, taking that upstream approach too, taking it away from just individuals that are just constantly being exposed to this. And lastly, if I could just mention one more thing, I think we do also have to recognize that there are some really positive social media platforms out there too, and some also positive influences there too. So even though we know that there's been a lot of harm that has been caused, I think there is some good movement, at least in some momentum in some platforms that really are positive and have good framing for better direction of promoting health amongst lots of kids and teens and youth. And I think Sylvia was going to add something.
Yeah, so my oldest is 12, so we're right in there with the social media and the social media issues and things like that. And we can see how it has become, it's so much bigger and so much more out of control than I ever thought it could be. And you can even see the shifts at the level of the schools when they started to ban phones this year, like to keep the phones out of the classrooms and keep the phones out of the lunchrooms. Is I've heard comments from even teachers that are saying, at one point, kids were completely quiet. Like my daughter went to a birthday party once and everybody was on their phones and nobody was talking to each other. So it's gotten so pervasive, and I completely agree that it does have to be at the systems level, because since phones have been banned at some schools, I hear teachers now telling me, oh, there's actually like talking now in the lunchrooms. So there's like actually conversations that students, and now we're having like the loudness of the typical lunchroom, whereas we didn't have that for a few years because everyone was on their phones. So I do think that it does have to be rather at an individual level, it does have to be at a systemic kind of governmental or systemic level that we have to be able to address these issues with social media and how it promotes body image and how it can just like in every part of, I guess, of what we're doing,
how it
influences everything.
Yes.
Yeah.
We have another question. I just don't want, because we are short of time. Yes, please.
Very shortly, and we have to rebuild what we have done wrong during the pandemic. Even the first grader were on Teams most of the day with their teachers. So public health has to address that in the future. And the recent commission in Quebec was not able to conclude if do we have to make policies to avoid social networks, at what age, 15, 16, there was a big debate in Quebec recently, and they were not able really to conclude anything. So because people were presenting different things. things. So thank you again for challenging us with that question. It was very inflamed.
I mean, this question has a very broad response if you want to count on, because there are a lot of factors, misinformation, people are getting influenced, there are system changes needed, some things need to be banned, there are algorithms and all those. It can go on if we want, So I just want to conclude it. Do we have another question, Doug?
I think that was our last question.
That was our last question. Thank you, everybody. Thank you all the panelists for your insights, honesty, and depth to understand obesity as a disease and take care of the obesity care in a sense that is the empathy driven, So if there is a one takeaway for today's discussion, it should be that shifting the blame to understanding the obesity as a disease is important. And it's not only understanding the obesity as a disease, it should be compassionate care, which is empathy driven. And we need a lot of collective actions to make the changes in the society where we respect the individuals as an individual. We don't lose connections. And thank you so much. I hope this conversation inspires you, new ideas, new collaborations, and the commitment for the advocacy for the change and call to action for the obesity care. Let's keep this dialogue going on in the networking session after this. We don't have much time, but if people are available, please stay, have a food, and talk to each other. Thank you so much. Thank you, Douglas.
Muhammad Ilyas, thank you so much. Thank you for bringing this conversation to ForSpace. Thank you to panelists. I think we should clap. Let's clap. Okay, just gonna let you know, those of you joining us online, we're gonna close up the Zoom and the live stream now, but excuse me, this conversation remains available on our YouTube channel, and you should revisit it and you should share it. You should also have a fantastic weekend. Thank you. Those of you here with us still in the space,